Good afternoon, everybody. It's my pleasure to welcome you to our symposium on full physiology, sponsored by Abbott. I also welcome you on behalf of the team here, the spokesperson, Dr. Pereira, and the three discussants and speakers you will get to know during our session. I would like to give a brief introduction to this topic. As you are all well aware, intracoronary physiology is important. When you look at the current guidelines on chronic coronary artery disease, there is a clear recommendation to assess epicardial coronary stenosis if there is no other information on ischemia. And we are also very forced by the guidelines to assess post-PCI results by using intracoronary physiology. And there is increasing evidence that when we have a patient with angina symptoms, that microvascular coronary disease is in almost 50% of the cases actually the reason of the symptoms. So in order to tailor medical therapy in this particular patient cohort, it's very important to make a precise diagnosis. And this is the reason why we are here this afternoon. And these are our learning objectives for this session. So we would like to understand the concept of full physiology and why it should be considered. We would like to teach you how full physiology can be easily implemented in everyday clinical settings. And it's also our task to make you understand the implementation of the latest ESC guidelines I just showed you for managing patients with ANOCA. And before we start with the first talk, I would like to show you two poll questions to be a little bit more interactive and just also to get a glimpse on the experience you have already. Maybe you can show the poll question, the first one. So the first question was, it was not displayed here, I'm sorry. So the first question was, when do you routinely assess epicardial physiology in your clinical practice when indicated? And the possible answers were always, sometimes, or never. And I think this is already very positively surprising that most of the people here in the audience are already using it, so very conform with the guidelines. And the second question is, how often do you routinely use it to assess microvascular physiology? And I think this is also what we somehow expected here, and which is also our task to somehow get more information on this topic, then because still 50% of the people here in the room are not using it on a routine base. So hopefully this will change after the symposium. And it's now my pleasure to announce the first speaker.
Our first speaker is Dr. Gianluca Campo, and the topic is full physiology. Now, Gianluca and the team at Ferrara were probably one of the first to use the term full physiology, and here to tell us a little bit about the history of that and what it actually means. Gianluca, thank you very much.
Thank you, dear colleagues. It's a pleasure to be here and to have the opportunity to introduce and to discuss with you about full physiology, my conflict of interest. So, full physiology, what is it? We started 5 years ago with a logo and with a slide. And we will see this slide in the next minutes. Full physiology is a peer-to-peer initiative, so from interventional cardiologist to interventional cardiologist to promote and diffuse the use of invasive coronary physiology in daily practice. Now, full physiology is educational material, a website, scientific meeting, publication, and we are very proud also to have some ongoing study under the logo at the Full Physiology Group. We started 5 years ago discussing between friends about the Italian data. The Italian data were dramatic, with a very low penetration of coronary physiology, and only few operators in few centers using microvascular assessment and post-PCI FFR. So we decided to promote a very simple and clear idea. So if you decide to open a wire, a pressure wire, please use this wire for all its value. So don't limit one index, resting index, FFR, but try to take all the possible information from this wire. So, for example, if you start with the epicardial assessment, collect resting and hyperemic indexes. And if you have a positive FFR, please perform the pullback. And we will see why this. On top of this, please, if you perform PCI, remember to repeat post-PCI assessment and don't forget to integrate the information of epicardial assessment with microvascular assessment. On the other side, if you have a patient without obstructive disease, don't forget to associate the information between microvascular assessment and acetylcholine test. So in daily practice, what we did. So when you have a patient with obstructive coronary artery disease, so intermediate disease, you have to put the wire down in the vessel and start collecting the resting index, so the resting full cycle ratio, RFR. After this, you switch the modality of the console from RFR to CFR IMR, and you start collecting the resting transit time. After this, you may induce hyperemia, and one after the other, you may collect in few seconds hyperemic transit time, FFR as a single point in the distal vessel, and after this, if positive, start with the pullback. The pullback is important to have both the pressure trace along the vessel and to have also, now available for all of you, the PPG index, so the pullback pressure gradient. Why this is really important? This is the key point when we talk about full physiology. Because only with all the available information, you can interpret very well the patient that you have, the disease, and the right treatment. For example, the pullback is crucial to differentiate focal and diffuse disease. So this is really important to plan your procedure, to predict the result, and in particular, if you have a disagreement between resting and hyperemic index, only having microvascular assessment and diffuse disease or focal disease, you can interpret which is better for the patient, if the resting index, or to follow the resting index, or to follow the hyperemic index. On the other side, in presence of microvascular dysfunction or diffuse disease, you can anticipate and justify some residual symptom after the PCI procedure. On the other side, if you have a patient without obstructive coronary artery disease, first, RFR and FFR are really important to confirm the lack of obstructive disease. In second, only integrating the information from CFR and IMR and acetylcholine test, you can perform the right diagnosis, the right endotype of the patient, and tailoring the treatment. Obviously, in daily practice, this has shown an incredible impact. Because first, full physiology is now endorsed by guidelines, and only with the full application of all the indexes, you can achieve a good result for your patient following current guidelines. Second, the discrimination between focal and diffuse disease is really important for your practice. Because when you perform the pullback and you observe this curve, so this focal step up, you are working with high-risk plaque. And in particular, you know that your PCI will be very, very easy with a great result and a lack of residual symptom. On the contrary, look this, the FFR value is the same, but the pullback curve is totally different. Here we are a very slow progressive increase in the pressure trace. This is associated with diffuse disease, so you can perform PCI. But you have to know that there is a higher risk of periprocedural MI, periprocedural complication, and in particular a higher probability to residual symptom after the procedure. So it's really important in the way that you communicate the result of the procedure to your patient. But this is the most important thing. When you have all this information, you can tailor the treatment. We talk every day about tailored therapy, this is the best tailored therapy that we have. It's a jump in the future because you can add at the discharge ranolazine, nebivolol, amlodipine, if you have microvascular disease. You can prefer verapamil or diltiazem and not beta blockers if you have a vasospasm. And on top of this, you will have a procedure checked step by FFR in the indication and the final result. We have some data showing that this idea works very well every day. Yes, just two papers before to conclude my presentation. The first from Spain, the AID-ANGIO trial presented last year at the EuroPCR, showing two important things. Full physiology approach change your clinical practice in 50% of the cases, but this is the most important thing. If in your daily practice you think to identify the right ANOCA endotype only in medical history and angiography, you will be wrong in 80% of the cases. And now, this is a great paper published by Antonello Leone from Rome. This is the additional value that physiology gives you in every day, in every procedure. As compared to RFR or FFR assessment, to perform a full physiology approach, reduce adverse events, reduce hospitalization in the follow-up, improve angina classes in each patient, and in particular, avoid to repeat useless tests during the follow-up, with an incredible healthcare cost saving. So in conclusion, full physiology is like a mindset. You start with some procedure, one procedure by week. After this will be one procedure by day. And you will increase the number of procedures because you will see the great benefit of this approach in your daily practice. And obviously, after the first procedure, you understand that you don't need increase in time, in cost, and you will have a great advantage in terms of quality of life and outcomes for your patient. Thank you.
Gianluca, that was a great presentation, really nice summary of how we really need to move forward and to this mindset, as you put it. Now we'll take some questions from the audience, but while we're waiting for you to gather your thoughts, I'll just give you my perspective on what you've said. The beautiful thing about it is that we already have the kit in our cath labs. All we need to do is to change our mindset and the cath lab protocols. It's not that any of us need to go and acquire some fancy new kit. This is assuming you do pressure wire studies in the first place. So the first survey response showed us that a lot of you do this already, but what we now know is it's no longer adequate to say that we have done a spot FFR or RFR in the distal vessel. If there is epicardial disease, we need to know the pattern of disease to predict the response to our PCI. And if there isn't, we still need a diagnosis. We can't send the patient home without knowing what their microvascular function is. So those are the goals. But Gianluca's really nicely shown that if you just use this protocol, then you'll have all of the answers fitting into all of those scenarios.
Yeah, it's really important in particular because frequently we talk about physiology just to say yes or not to a procedure, but this is not enough because when we have a patient, as you see before the procedure, to the medical history, the EKG, the echo, so you need a lot of information to manage very well the patient. Full physiology is the same thing. So it's not just yes or no to treat a vessel, but is a lot of information regarding microvascular assessment, vasoreactivity. This information are really crucial also to interpret better the history of the patient, the symptom of the patient, and the management.
Yeah, and what you showed from AID-ANGIO, the Spanish study, and the more recent work is that when we think we know what's going on, we get it wrong so often. If you then try and validate it or prove it with physiology, you just can't guess the physiology when you're sitting in an outpatient clinic, can you?
Yeah. So regarding physiology, now we have a lot of data also regarding the possibility to tailor the treatment. I believe this is the most important thing, because when you have the possibility to manage, for example, diffuse disease with a combination of PCI or medical treatment, a tailored medical treatment, obviously the probability to have a patient freedom from angina is higher.
Yeah.
That's the same thing for a patient, for example, with non-obstructive coronary artery disease. A lot of my colleagues perform only CFR, IMR assessment, and if negative, okay, the diagnosis was vasospan. That's not true.
That's definitely not true. And actually, there's a question from someone in the audience: why acetylcholine at the end of your protocol? And I think that's worth us talking about, because all other elements of this you should be able to do in your own cath labs with no extra setup at all. The use of acetylcholine testing is safe and it's relatively straightforward, but it does require you to set things up. Firstly, the supply of acetylcholine comes from our ophthalmology colleagues everywhere in the world, as far as I'm aware. And that's a little bit tricky, so you need to work with your pharmacies. And then there are some safety precautions that need to be taken to deal with the bradyarrhythmias and so on. They're not difficult, but they need a sort of dedicated setup. But what Gianluca just said, I can only sort of firmly echo the lack of a diagnosis after your normal physiology testing of epicardial and microvascular disease doesn't mean that the diagnosis of exclusion is vasospasm. You really need to find whether it happens or not. Again, quick show of hands. How many people use acetylcholine during their physiology testing in this room? Actually, that's a higher proportion than I thought.
So just one question, Gianluca. This was a fantastic overview, of course. And when I speak to people about this kind of approach, there's always two questions that you get. One, how much time do you spend on doing this full physiology approach? And you have a lot of experience of this, implementing it in your routine clinical practice. So that is one. And the second was slightly answered by Divaco, but how many times do you see complication of this kind of an approach?
So regarding the time, this is a very important point. At the beginning, you can take some minutes to organize the system. But now with the current console, and in particular when the nurses are confident with the drug, we take to perform all the assessment no more than 6 or 7 minutes, because all the steps are one after the other. And in particular, if you limited the assessment to epicardial and microvascular, because it's the first scenario, so the step between resting index, hyperemic index, and pullback are very quick, subsequent one to the other. On the contrary, to take acetylcholine test, this is related to your second question, you need more time, because the infusion of each step, normally the steps are 3, so 3 different doses, 20, 50, and 100 micron of acetylcholine. So you need at least 1 minute, 1 minute and a half for each step, and a stop of around 1 minute between one step and the other step.
So before we move on, I'll just answer a couple of questions. Acetylcholine is not available in India is one of them. There are some others who say, if you don't have acetylcholine, are there any other alternatives? I'm afraid not at the moment. And there isn't a non-invasive test that reproduces what we can do in the cath lab. It's an intense area of research, but right now, if you don't have acetylcholine, you can't really do the spasm testing.
So maybe I may ask you one other question, since you are really well experienced. So if you have an epicardial stenosis and you are assessing the microvasculature, how valid is it in this situation, and what would be your suggestion? Because we know that even if we have one short stenosis in a vessel and we treat it and the patient might come back, I mean, the percentage is not that low. Is it really valid to assess the microvascular function with the epicardial stenosis, or do you have to bring back the patient?
This is a great question. So in our approach, we try to be really pragmatic. The idea behind is to give more information, so not the definite answer, but more information to interpret the symptom of the patient at the moment of the procedure in the next weeks. So the idea, as you know, CFR value is related to both epicardial and microvascular assessment, microvascular function. On the contrary, IMR is more specific and more dedicated to microvascular function. So be careful with the interpretation of the data. We use this data also for the management of the patient.
And I suppose we should make people aware that there is a new index in town. It's microvascular resistance reserve. Of course, we come up with acronyms every EuroPCR, more or less. But microvascular resistance reserve is simply your CFR corrected for your FFR. So it's CFR divided by your FFR with some adjustments for what happens to your aortic pressure during hyperemia and rest. And that is probably the most robust epicardial disease independent measure of microvascular function. And so it is possible to the ideal scenario is that we should know before we treat the epicardial vessel whether when your patient comes back to clinic, they're going to complain of angina because they've also got a lot of microvascular dysfunction. So microvascular resistance reserve can be calculated, and it does require some measurement of flow, however you do it, with bolus thermodilution, with Doppler, or with continuous thermodilution. But that's perhaps slightly more advanced.
And maybe one more question, because we usually do it in our center, that we measure left ventricular and diastolic pressure, because we know that left ventricular dysfunction is an important predictor for microvascular dysfunction. So how do you do it in your center, and do you recommend to assess it?
Normally, in this case, so if you are talking about chronic patient, obviously the index that we normally use is left ventricular ejection fraction. So if the left ventricular ejection fraction is preserved or mildly reduced, we have solid data showing how the assessment is very, very reproducible. Obviously, in the acute setting, in patients with very low ejection fraction, this is a key point to be careful in the interpretation.
Okay. Any more questions at that point? Okay, then I think we move on. And we are now happy to share with you one case presentation, patient with stable and recurrent angina. And Damien Collison is going to present this case.
Thanks, Tanya, and good afternoon, everyone. This is a case I had in the cath lab last week, which I thought was quite interesting and a nice illustration of how we may start to move beyond just using FFR as a single endpoint measurement to guide our decisions and move towards a more objective quantification of the pattern of coronary disease we're dealing with and what the likelihood of success with treatment from that's going to be. So there are my disclosures. So this was a 59-year-old gentleman, ex-smoker of a number of years with ankylosing spondylitis, osteoarthritis, hypothyroidism, and somewhat overweight. You can see this was the ECG that was sent through to our centre at the end of last November with ST elevation in the high lateral leads in particular. So that was his initial shot of the left coronary. You can see hanging the dye hang up there towards the end of the run of what turns out to be quite a substantial first diagonal branch occluded, which would of course fit with the pattern on his ECG. So he'd had about 10 hours of chest pain. He was a somewhat delayed presentation to us before he called an ambulance and was then brought directly to the centre. So he underwent primary PCI to that occluded diagonal branch, drug-eluting stent, 275 non-compliant post-dilation, and a substantial infarct and a rise in his troponin as evident there. So had an uncomplicated recovery, really. He had mild to moderate LV dysfunction on his echocardiogram a couple of days later with wall motion abnormalities, as we'd expect with the affected territory. But uncomplicated and was actually fit for discharge home just over the 48-hour mark from admission. So the plan was to bring him back for a staged assessment of his residual moderate but somewhat diffuse looking coronary disease in the LAD in particular, and to just get another look at how things had settled with the diagonal branch. So he returned to us just last week, in fact. I had a chat with him on our day ward beforehand. So unfortunately, he hadn't been called to cardiac rehabilitation and been kind of waiting on that, and as a result had curtailed his activity. So he really wasn't back to his usual pre-MI level of activity. In fact, he told me he used to go for regular runs, but had just been avoiding that. It was quite hard to unpack as to whether he did have angina or not, and he was unsure. Obviously, he'd had to stop some of his anti-inflammatories following the MI, the toracloxib in particular. So he was getting a little bit of flare musculoskeletal pain as well. But as I say, we had planned to bring him back for a staged physiology assessment in any case. So here's how things looked 6 months down the line. You can see that diagonal branch has really come back into its own, so a very important branch, and easily see why it caused a substantial infarct for him. But you may notice that the edge of it doesn't look too clever just at the proximal edge of the stent. The LAD itself, I was inclined to think, was probably not going to be functionally significant, but I was keen to assess that. And you can see on the LAO caudal or spider view there, again, giving the impression that the stent is either oversized or there's a substantial step up just at the inflow to it. So we started off with a physiology assessment in the LAD. My sensor was down here, and these are our resting measurements. So you'll see both resting indices were negative, a PDPA of 93 and an RFR of 92. So I could have stopped there, I suppose, but I didn't. FFR was negative at 82, quite distal in the artery as well. And I have, as with following on from Gianluca's full physiology, my practice would be particularly for lesions that I think I'm likely to defer. I'm much more reassured to see that there's good healthy microvascular function and a robust coronary flow reserve, even with a borderline or grey zone FFR measurement. That makes me much more comfortable about deferral. So you can see we had super physiological levels of coronary flow reserve here at 9, which is an overestimate potentially, but I think speaks to the fact that it was normal and that was conclusive. And the IMR was nice and low as well. So we've got an endpoint FFR measurement here of 82. You could say stop at that, but of course you shouldn't put a pressure wire down without withdrawing it and looking at the longitudinal assessment of the pattern of coronary disease. So I've flipped the image here just to make it a little bit more like a pullback with an imaging catheter, really. So you can see our start point is number 1, and you can follow out the pattern here as well. Number 2, around the chicane, nothing happening here. Now, the interesting points are at 3 and 4. So these are at either side of this large septal branch here with moderate narrowings there and just in here distal to the diagonal origin. And this little bump here is just the catheter being pulled in slightly, and you can see that levels off. At the end, we've no drift, we come back to 1. So this is a steady, continuous pullback. I'm not stopping, I'm not pausing, and I'm just gently pulling this back. And you can see our time index is here down the bottom. So I've given from yellow line to yellow line, I've given this 38, 39 seconds. So that's relevant for the next metric I'm going to discuss, which we'll move on to. So right now we could take a poll in the room as to who thinks that's focal disease and who thinks it's diffuse. I'm not going to, and the pragmatists among you might actually say it's a mixed pattern. Personally, I think it's probably diffuse, but it would be nice if we could all have a metric that we could agree on that says this is or isn't focal. So that's where the pullback pressure gradient or the PPG index comes into things as to how we could maybe have a language we can quantify this focality of disease. What the metric is doing, essentially, the software is analysing the maximum pressure gradient within a 20 millimetre segment, and you can see that spike in the FFR gradient across that lesion. So this is an example of a very focal lesion. Here's the formula for how it was originally derived. So again, you're looking at that FFR gradient within your 20 millimetre window as a proportion of the overall FFR gradient along the pullback, and similarly then looking at the concentration of disease against the overall vessel length, and that just gives us a metric. So I'll illustrate that here. So here's the same picture you've seen, and here is the PPG for this vessel. So what's happening here, there's a lot of information around this area I want to highlight. Between these two white lines, what you're seeing is an increasing density of the red lines. So this is the focal aspect of the disease, but it's not a particularly focal result overall. In fact, this would be considered diffuse with a PPG of 52. And what it's telling you is that between those two white lines, let's say, for argument's sake, you were to place a stent from there to there, your delta, or the FFR gradient, is about 0.09. So approximately 50% of the 82 value is occurring within this region, but FFR negative. So I'm quite comfortable in this vessel, a diffuse gradient, objectively quantified, a robust CFR, and a borderline but negative FFR that I would not do anything to this LAD. Now, particularly on the still here, you'll see my concern was actually about the inflow at the diagonal branch. So I went on to pop the pressure wire into the diagonal as well. So here we have borderline positive PDPA of 91, an RFR of 87, again suggesting that this is across the revascularization threshold. Here's the FFR value again, quite borderline. I had to repeat this due to an issue with our pump. The first time I did it, it was 81. The second time it was 79 at a steady state. Now you can see on the still here, this really brings home for where the issue was at the edge. Now to my mind, there's no argument that that is a focal pressure loss just by looking at it with the eyeball test. This artifact here is just me flushing the catheter. You can see there was a small but acceptable amount of drift after we pulled back for the second time. So if we apply PPG to that, you can see here, and I'll show you the side-by-side comparison in a second, a much higher density of the PPG. This is 68, a delta of 14 FFR units across here, accounting for 73% of the gradient. And when you compare the two side-by-side, or 52 and 68, you can appreciate the difference there between them. So in the end, how I treated it was just, I was aware there was moderate atheroma here. I did not want to get into bifurcation stenting for a vessel that was functionally non-significant, and we treated this and got a nice result with a drug-eluting balloon back out to the ostium, as you can see there. So in summary, this was a staged and planned assessment of moderate non-culprit LAD disease following a gentleman with a lateral STEMI 6 months prior. Some diagnostic uncertainty as to whether he did or didn't have angina, and so we performed comprehensive physiological assessment of the relevant vessels. So his mild to moderate male LAD atheroma had a borderline negative FFR value, but a very diffuse pattern of disease with good microvascular function and a robust coronary flow reserve. So I'm entirely comfortable managing that artery with medical therapy. His diagonal, on the other hand, as expected, whether it was a geographic miss, some in-segment restenosis at the edge, either way, what we were seeing was certainly a focal pressure loss across the inflow, and that was successfully treated with drug-eluting balloon without getting into involved bifurcation intervention. So, happy to take any questions.
Damien, thank you so much for this great presentations. Are there any questions from the audience? Maybe while we are awaiting your questions, maybe I might ask one question. So I think when we looked at the LAD, the proximal LAD, I think you are absolutely right. We have a gut feeling about that. It's important to measure it. There is very diverse data on using resting indices and FFR on proximal LAD. So what's your approach to proximal LAD assessment?
So I measure them, but I would never use it as my sole adjudicator, particularly for the LAD. So I think it's part of the full physiology package. I do it certainly, but no, I wouldn't have made a decision on the basis of that. And as I say, I think I'm more comfortable and more reassured deferring lesions, the more information I can have about the physiology. And as Gianluca has pointed out, we're not going to say it doesn't add a little bit of time, but the more you do it, the better you are, the quicker you are, the quicker your staff are, and it doesn't add an awful lot. The equipment is already down there with your pressure wire X, and you get a lot more information, and I think can make better decisions for your patients too.
You also nicely demonstrated the concept of PPG. And in the example, you showed us that one patient was 50% of pressure loss and the other one 70-something. So what is actually the cutoff we should use?
So this is still evolving really, but the largest piece of data we have on this came from the PPG Global Registry presented here at PCR last year. That was defined basically on a median split. So the cutoff was 0.62. So below 62 or below was diffuse and above was focal. You know, it's like anything, how you draw that up. If you put that into tertiles, of course, you can be more reassured that the higher tertile is going to have. What we know about it is that it correlates with the delta FFR. So the larger the focal pressure loss, the more gain you can have by putting a stent from normal to normal either side of that. And we know that that has a reasonably good correlation with freedom from angina afterwards as well. So this additional piece of information going into a PCI can potentially allow you to predict angina relief for patients with true angina related to their epicardial disease. Of course, it's more complex if they have coexistent microvascular dysfunction or non-anginal chest pain and bystander coronary disease. But I think applying all these metrics allows you to filter through some of that as well.
There are a couple of questions. I think one's been answered just now. What are the PPG cutoffs? I mean, as you say, Damien, I think we need more data, and the biggest series out there suggests that the median of 0.62 really does differentiate between intra-hospital outcomes and longer-term outcomes as well.
Yeah, so I mean, what we saw on the data, of course, was there was a higher rate of MI in where diffuse disease was subjected to PCI, which largely related to peri-procedural events, and of that probably side branch loss, etc. So imagine you get into this procedure with the best of intention. Like, for example, I had tried to stent that LAD and lost the diagonal branch and made the whole thing a lot more complicated for a functionally non-significant LAD. So I think knowing all this information goes into it saves you and your patient potentially pain and side effects and complications of stents they just shouldn't have had placed in the first place.
Yeah, I mean, it's a continuous variable. You can have values approaching 1, which are extremely focal, and I've certainly seen values as low as 0.3. So it is a continuous variable. We like binary thresholds, and if you need one, then probably the best one to use is that PPG global study median, which is 0.62. There's a question about drift. I think that's quite important in all of our talks. How much drift is
acceptable?
Acceptable,
yeah.
and
so, I mean,
when do you go back and do all your measurements again?
You'll see it vary in papers. I think 0.03 is kind of accepted. 0.02 if you're more stringent about it. There is some software does drift adjustments, which I guess it makes the numbers go away and solves the problem. But I think for the most part, small variations around about the cutoff point. I think we have to stop being so rigid about the red light, green light approach to 0.80 or 0.75, and all of this additional information allows you to make more nuanced decisions around whether you do or you don't stent it. We're physicians at the end of the day. We shouldn't just be making decisions on one number or either side of it, because we know that's not how things work. So
yeah. Gianluca, did you have anything to add?
Yeah, just a brief comment about, I believe the most important thing is when you have a FFR value around 80, so in the gray zone, I believe the really additional value is the assessment of the microvascular assessment to understand if the hyperemic response was good, and obviously if you can rely in the FFR value. So your case is wonderful because 80.2 FFR value with some dysfunction in the microvascular assessment can change your approach, in particular if you have a focal drop. In my practice, I can tell, when I have a focal drop, a FFR value 82, 83, if there is microvascular dysfunction, I can add some elements also to decide to see if to proceed or not with revascularization.
There are lots of questions coming, which is great. Keep them coming. We'll field some of them here, and I'll try and type out some thoughts for the rest. But one, I think this is a really good practical question. Nitrates. Do you inject nitrates before assessing full physiology? And do you give repeatedly if the patient, during the case? I'll give you a quick answer. Yes, absolutely. All of these measurements need to be done after you've administered nitrates. And if sufficient time lapses, you may need to repeat it. Now, what you haven't asked, but the slightly thorny question is, should you give acetylcholine before you do your full physiology assessment or afterwards? And if after, how long after nitrates do you need to wait? And I'm going to ask Gianluca for his thoughts, but my own practice is that we give nitrates at the start of the case, and usually if 15 to 20 minutes have lapsed, I'm very happy that we're going to see the acetylcholine response. All that the nitrate does to your acetylcholine response is it makes the test even more specific, if at all. It might reduce your sensitivity slightly. Gianluca.
No, sure. We did the same thing. So nitro, just at the beginning of the assessment, is really important to wait after nitro injection before to calculate the resting index. This is a very important point because remember that resting index is a resting index. So when you inject nitro, there is 1 minute, I believe, 1 minute and a half of mild, very mild hyperemia. And you have to observe the resting index value going up, going up, going up, and you need to stabilize the value for some seconds before to start the recording of the value.
Tim, any thoughts?
No, I think there's multiple ways to do this. I think there's no real data on which approach you need to use. acetylcholine first or full physiology first. You will see in my case that we do it the other way around. There's reasoning behind this as well. But I think there's studies doing both ways. The diagnostic yield of both approaches is very high. around 70 to 80% for both of these approaches. So I think it's much more relevant what is applicable to your clinical practice than to hold on to a single protocol that is used by somebody. So I think that's really important.
Tim, that's perfect timing. So maybe ask you to swap and bring up your talk, because we're going to delve into this in a little bit more detail. Beautiful case coming up from Tim. I mean, Tim's been doing physiology. Don't think you called it full physiology, Tim, but you've been doing full physiology for a long time, since he was a fellow at AMC many years ago. So look forward to hearing your case.
Thank you, Devaka, for the introduction, and also thank you for the organizing committee for the invitation. And for me, it's the task to present a case of full physiology in ANOCA. And these are my disclosures. So I took with me a very typical ANOCA patient, which is a female, 55 years old, which has a medical history of treatment-resistant hypertension. Since 2018, she's known with Bechter's disease, and she presented to the referral center with angina, stable angina, CCS class 2 to 3 in 2023. She had a rubidium PET done there, which did not document ischemia, and had a low-dose CT acquired with no coronary calcifications. The echocardiogram was normal, both in systolic and diastolic LV function, and the coronary angiogram that was performed there only documented minor wall irregularities. Last year, she was referred to my outpatient clinic because she experienced progressive angina, CCS class 3, despite guideline-directed medical therapy, and she was referred to us for further evaluation of her ANOCA. So she reported at my outpatient clinic progressive chest discomfort both in rest and during minimal exercise with radiation to the back and both arms, which was CCS class 3 to 4 despite medication trials with metoprolol, calcium antagonists, nitrates, and ACE inhibitors and spironolactone that she used for her hypertension. So in shared decision-making, we decided on coronary function testing because of her persistent symptoms. So first, we performed the baseline angio. Here you see the right coronary artery, which is normal. On the left side, there's some wall irregularities. And then we have this ANOCA patient. So now what? In this case, we, of course, in shared decision-making, decided to go for coronary function testing, but this is now also supported by the ESC guidelines that were presented last year. So in this case, we're here on the bottom left, where she had non-invasive assessment, she had invasive assessment, she was treated for ANOCA, but still she had persistent complaints, and then we have a class 1B recommendation to perform a full physiology assessment in these kind of patients. So in our hospital and also in the whole of the Netherlands, we use the procedure that was presented also in the guidelines, where we do S2 choline testing first. We actually don't use the 2 micrograms dose. We do 20, 100, and 200 micrograms by manual bolus injection over 60 seconds in the coronary artery, while continuously monitoring the EKG and the symptoms. And only afterwards we give nitrates, and then we perform adenosine testing to calculate coronary flow reserve and microvascular resistance. So that's what we did in this case. And 20 mics of S2 choline, she reported some recognizable complaints with a visual analog score of 4, with no EKG changes, which changed at 100 micrograms. Her complaints worsened, and we saw mild SC segment depression, as well as some narrowing of the coronary artery, but not up to the 90% that we use to define significant epicardial spasm. So we go to 200 mics, and there we saw subocclusion of the apical LAD, right there, as well as the distal circumflex coronary artery with the diffuse SC segment depression and a visual analog score of 8. Then we gave nitrates, which also almost led to an almost resolution of her complaints, as well as SC segment resolution. You see that also both the LAD and the circumflex responded to the intercoronary infusion of nitrates. In our hospital, we typically then perform a re-challenge using the maximal dose of acetylcholine that was used during the initial test. So we exclude any effect of epicardial vasoconstriction to also unmask potential microvascular disease and to get some response or some insights into to what extent this patient might be nitrate responsive in terms of treatment at the outpatient clinic. So in this case, we performed a re-challenge using 200 mics of acetylcholine. And she had the same angina that she had during the initial test with the same SC segment depression, but there was no constriction in the coronary arteries. So We then follow with the rest of the full physiology approach. So we start with the pressure assessment. In this case, we took an RFR assessment, which was 0.91, and then we move forward to bolus thermodilution. So to perform coronary thermodilution, you need three things. You need the wire, which is in this case pressure wire X from Abbott. You need the coroventus system, which allows you to measure all kinds of physiology indices, and you need a hyperemic agent. And this is also just what you have in the cath lab. We typically use intravenous adenosine, but you can also use intracoronary papaverine, intracoronary nicorandil, which is used in the Asia-Pacific region, intravenous regadenoson, and recently published by the group from Madrid, intracoronary adenosine for coronary thermodilution assessment. So what do? You have a syringe with 3 cc's of saline, room temperature saline. The catheter is in the coronary artery, and the wire is distal in the coronary vessel. So first, we do bolus injections during resting conditions in triplicate to allow assessment of the mean transit times in rest. So the bolus of saline will cool down the sensor element on the wire, which will heat up again. And from this thermodilution curve, the system will determine the mean transit time. We perform the same procedure in hyperemic conditions using one of these hyperemic agents, and then we get usually a much quicker mean transit time, which shows that microvascular function improved or that coronary blood flow improved. From these data, the system automatically calculates the coronary flow reserves as the mean transit time in rest divided to the mean transit time in hyperemia, and it also calculates automatically the IMR value as the distal coronary pressure times the mean transit time. So these are all automatically provided. In this patient, we had a CFR of 2.2 and an IMR of 2.3, and in this case, the FFR was 0.89 of the LAD. So if we go into interpretation of these kind of coronary flow and resistance values, then I typically use this graph from Divaco Pereira's group, where there's actually 4 groups that you can discern. One, if your coronary flow reserve is normal, and we typically use a 2.5 threshold for defining normal versus abnormal coronary flow reserve, then we consider coronary microvascular function relatively normal. On the other hand, if the coronary flow reserve is abnormal, there's 2 types of coronary microvascular function that you can discern. One is the case where hyperemic microvascular resistance is normal, as in our patient, because the IMR value was below 25. We typically frame this functional coronary microvascular dysfunction, which seems to be due to a low vascular tone at rest and a low vascular tone at rest. Then on the other hand, you have coronary microvascular dysfunction, which is called structural CMD, and this is the case when hyperemic microvascular resistance is abnormal, and this is typically due to a high vascular tone at hyperemia. Then this odd case where you have a normal coronary flow reserve and an abnormal hyperemic microvascular resistance, this is still a topic of debate, and that's something that we'll get into in the future. So for diagnosis and treatment, if you have this diagnosis, then there's a scheme of treatments that you can use. And for each individual patient, you will need a combination of these drugs to optimally identify or to optimally treat the individual endotypes that you documented during the full physiology approach. So in this case, you have combined epicardial and microvascular vasospasm, as well as a form of functional coronary microvascular dysfunction, which was documented using the full physiology approach. And in this kind of complex combined coronary vasomotor disorders, we use a treatment with empiric drug combinations targeted to these individual endotypes to treat the patient. Importantly, this is becoming even more relevant in the near future because there is new innovative medical therapy approaches emerging, as well as device-based therapy like coronary sinus reducer therapy, which will only make this more relevant. Thank you. I would like to give the stage back to the chairman.
Thank you so much for this very illustrative case, and I think also a very typical case. I mean, as you just showed us, a patient who underwent coronary angiography before, still persistent angina, and I think this really shows us very clearly that we should never discharge a patient from our cath lab just writing in the report that there is minor atherosclerosis, but really no clear diagnosis, because I think that's really an issue, and the patient will come back and will not get dedicated treatment. Any particular questions?
So, if I can ask you just a brief comment regarding the management of patients with microvascular disease, so for example, structural microvascular dysfunction. Because we talk in every session about medical treatment, so we have good data from ranolazine, from amlodipine, but we miss to touch a very important point, that is exercise training. We are collecting some data about this. There are other centers working on this. It is really important because the patient for chest pain normally don't perform exercise activity, don't perform. We are very confident performing exercise training after MI, but not in this kind of patient. Just your opinion about this.
No, I agree. There's a lot to learn still about the optimal treatment of this kind of patient populations, and there's two things that is important to realize, that in a lot of these patients, it's not a single issue that we identify during a full physiology approach. So, and that's also a little bit, I think, the comment regarding exercise training. Because if you put a patient with epicardial vasospasm as well as coronary microvascular dysfunction on exercise training, these patients typically do worse because they trigger their complaints only after exercise. So in our institution, we have a dedicated cardiac rehabilitation program for each of the ANOCA endotypes. So patients are referred there to an expert physical therapist that knows how to train these individual patients. And then you see that it boosts confidence a lot. So I think it's really important, but it's important to have the complete picture before advising patients this kind of treatment as well.
But yeah, I think you both make a really interesting point that is worth emphasizing. All of the focus so far in microvascular testing and the research around it is to make a diagnosis. But what we're now hearing is that you don't stop at the diagnosis. You use that information to guide what therapy you give patients. And some really interesting data are emerging that compared to an empirical approach where you just don't bring the patient to the cath lab and you give them all anti-anginal agents versus stratifying them by therapy, it's becoming apparent that those who respond to anti-anginal therapy and perhaps even exercise, I don't know the latter for sure, are those who have an abnormal CFR. That the response to anti-anginal therapy in terms of objective improvement in exercise capacity, you see in those who have an abnormal CFR and not in those who have a normal CFR. So knowing it not only gives the patient a diagnosis, but gives the physician a basis on which to start treatment. So that's even more reason why we should do the testing.
I completely agree, and I think also in terms of research, in the Netherlands, for example, ranolazine is not available because of the negative trial data in the past. So CHAMP CMD has until now not changed the reimbursement in the Netherlands. But we need this kind of full physiology approach to correctly endotype the patient so we can target these patients, these therapies to the correct patient, because then it has the best chance to improve patient complaints and also to get reimbursement in countries like the Netherlands.
So there are a few questions coming in. One I really like because it's a half question, but it says so much. The Warrior trial was negative, but which is an excellent unasked question. As you know, Warrior was a trial which didn't carefully endotype these patients. It completely speaks to the point that is being made. That was almost an ANOCA or syndrome X type population. And what we've learned time and again, and very recently in Warrior as well, is that if you don't endotype them and try and give them all one therapy, you will come up with a negative result. We know that. And now we have a trial that proves that. I hope that answers your question. Then there was another question about should we stop amlodipine before testing for spasm? I might just expand that out to say, should we stop all medications? What's your practice in the Netherlands, and Damien, what's your practice in Glasgow?
So if patients come in for coronary function testing as the goal of the procedure, then we typically stop calcium antagonists 2 days before, nitrates 24 hours before the procedure. That being said, we will present at EuroPCR clinical trial, which is called ANOCA on Thursday, in which we did not stop medication. Cormica did not stop medication before the procedure. And in the 8 angio, they just asked the patients to stop the medication in the morning of the procedure. So, and in all of these studies until now, and we will present the data on ANOCA this Thursday, but all of those studies have shown the same diagnostic yield of around 80% of positive tests. So regardless of whether you stop medication or continue it, regardless of which kind of procedure you follow, as to colon first or full physio or the pressure wire assessment first, the diagnostic yield is around 80%. So I think it doesn't really matter. And typically in my clinical cases that come to the cath lab, I would say, as long as the patient has complaints on their current medication, there's no reason a test would not pick up the issue when you stress them with acetylcholine and do microvascular function testing. That would be my opinion.
Yeah, I mean, I completely agree. I think that's the point, isn't it? The medications are not effective for the symptoms they're presenting with, or you wouldn't be going down the line again. But as Tim pointed out, we didn't stop treatments for Cormica nor for the ongoing iCormica trial. In fact, some of the difficulties with obtaining acetylcholine, for a long time we had to have that on a named patient basis, so there was no ad hoc testing. So maybe in rare instances you may choose in select cases to stop things, but not as a blanket approach to it, we don't.
Yeah, I also agree with all of those points of view that you don't need to stop medication to do your testing. And for that reason, the fact that they're on medication shouldn't stop anyone from going on to do ad hoc full physiology testing. If someone comes to the lab, you're not suspecting they've got microvascular dysfunction, go ahead and do the assessments anyway. The only thing that having a patient on medication could do is it might slightly reduce the sensitivity of the test. But if you have a positive test, when you've tested someone on medication, you can be fairly sure that you've identified the problem. Gianluca, do you agree?
Absolutely. We did the same, so totally agree.
I think I've tried to batch the questions, but I think that's what we've got from you.
Meanwhile, I might ask you one more question. So you showed in this patient from your case that the patient underwent PET-CT scan, and this was negative. So, I mean, we learned from the guidelines that we should send patient for non-invasive assessment first. So how much can we trust this? I mean, PET-CT is already a very advanced non-invasive testing tool. So what is here your experience?
Well, I think the future will likely change things as well, because you can see that in these kind of patients that keep having symptoms, you don't get the full diagnosis by a non-invasive test, even if you use a PET scan. You would have missed all of the vasospastic aspects. You can argue about the difference between the bolus term dilution results and the PET results, but this is, I think, a very detailed discussion about the intrinsic issues with rubidium PET versus bolus term dilution, and techniques do not conform optimally in some cases. That happens. But I think the wrong reasoning would be do a non-invasive test. If it's normal, stop thinking, right? Then keep reassessing the patient. And if there's persisting symptoms, just be aware that this whole part of vasoconstriction in the epicardial microvascular level has not been assessed using the PET. So I think that is the way I would go for it.
Yeah, I think that's a very important point you're making. And of course, sometimes we see patients who already underwent invasive testing and just negative, and then of course it's pretty clear. But I think you also make the important point, if we have the patient already on the table, we should not stop and send him for non-invasive assessment. I think that's very important, because we will never get the whole picture of it.
And usually this is quite a typical case in terms of presentation, but it's quite atypical in terms of referral timelines, because usually these patients have underwent multiple coronary angiograms already, which have provided sufficient opportunity to get the diagnosis. So that's something that happens a lot. Yeah,
and I mean, some of them really show up in the coronary care, so for in a chest pain unit, because they are in emergency. So this is also what we usually see in this kind of patients. Okay. Any more questions left we have to answer?
No, I don't think so. I'll just say that I think it's been a great session. If there are any burning questions, there are mics, so please stand up and ask your questions. But I think it's been a great session, and that case also shows that patients get their diagnosis too late. And we have the tools in our hands, in our cath labs, to make the diagnosis when we first see them. So I think the mindset needs to change.
Okay, so I would like to thank all of you to attending this session. I think we all learned a lot. Hopefully, the questions we raised in the beginning, you might give a different answer next time when we are all meeting.